I think I'll present next. It would be nice of you, Georgina, if you also said some kind words about me so people know who I am.
Of course, Ilia. Okay, so next we're going to hear from Ilia Stambler on recognizing degenerative aging as a medical condition, the computational, methodological, and policy challenges. So here we go. So Ilia Stambler, PhD, is the Chief Science Officer and Chairman of VTech, Seniority Association, the movement of longevity and quality of life in Israel. He is a fellow at the Department of Science, Technology and Society, the Bar Ilan University, Israel. His research has focused on the historical and social implications of aging and longevity research and mathematical modeling of aging-related diseases. He is actively involved in advocacy for aging and longevity research, serving as an executive committee member of the International Society on Aging and Disease and the Global Health Span Policy Institute. Okay, Ilia, over to you.
Yeah, I think that's more than enough at this stage. Thank you very much. Let me try to share my slides as well. I see it's not trivial for some people, maybe including me. Okay, that went smoothly, I think. Let me know if you hear me, you see me.
Yeah, can hear you, can see your slides. Yeah, perfect.
Okay, great. So I'll be talking exactly for 25 minutes until I think 4 o'clock. No, it should be 11. 4 o'clock. Yeah. So if I exceed, please remove me from stage, block me or anything. My topic is recognizing degenerative aging as a medical condition. It is a great honor to present on this topic at this conference, especially in this session that is dedicated to the connection of aging and disease. And why is this connection so important? We see that with aging, basically all diseases, not just chronic diseases, but many chronic diseases increase in incidence, increase in severity, increase in mortality. So if we are really serious about preventing age-related diseases, chronic diseases, we should be able to intervene into their common underlying risk factor or their common underlying cause, and that is the aging process itself. And that means, in other words, that we need to recognize aging as something that can be treated. In other words, we should recognize aging as a medical condition, because if you don't recognize something as a medical condition, you simply cannot intervene to it. There is no regulatory framework to intervene. So that's our goal, to actually intervene into aging. And there are many computational, methodological, and policy and regulatory hurdles that arise on this path of actually treating aging. The importance of treating aging should be understood by everybody by now, especially after the COVID period. We see that the most vulnerable people are the older people with the highest mortality, with the highest severity of disease. And that is simply because of their aging, because of especially the aging immune system. And that should be understood by everybody. Unfortunately, this logical step wasn't made. It wasn't generally recognized that in order to fight COVID as well, we need to intervene into aging, to improve the aging process, to fight immunosenescence. For most people, they perceive the virus as somehow separate from the risk factors, but the connection is there. We advocate for this connection a lot during the past 2 years with position papers, with research papers, with public announcements, with online conferences. We always try to explain that if we want to improve the situation in COVID, we need to address aging as well. And I'm happy to have collaborated with several people here on some of the papers, especially with Professor Caruza, with Alexei Moskalev, with Robert Chenhuajao. So we really tried to make this point strongly. Unfortunately, it wasn't widely accepted, but we will continue to advocate for this connection, for the amelioration of aging as a preventive measure, not just for chronic diseases, but also for infectious diseases such as COVID and the other health crises that will come after it, that will mostly affect older people. And I would argue that it is because of this lack of attention to aging, the lack of improving the aging process, that we didn't do so well in coping with COVID as well. We see that globally the life expectancy declined almost by 2 years. It's unheard of. It's the first major decline in 70 years after the Second World War. Basically, we lost about 10 years of progress in life expectancy. You remember how proud we were of our increase in life expectancy. That was an indication of our progress. Here, a lot of progress is gone. All our medical technologies was pretty much incapable to stop this decline. Right now, it is improving again. The life expectancies begin to climb again, but 2 years of loss is something we shouldn't take lightly. It should motivate us, especially as proponents of anti-aging, of health longevity, to intervene into aging more. I would argue that's also one of the motivation. And of course, we should remember that not only general life expectancy, but the health life expectancy declined, especially in the developing countries, less so in the developed countries. In China, actually, the general life expectancy increased a little bit, a few months. In countries like Netherlands and Italy and Israel, it declined by about half a year. So still, this is terrible. I believe this is quite appalling, this decline that we had. So it is our duty to at least get back to the levels of 2019, and then hopefully also resume our progress, also through the amelioration of degenerative aging processes as one of the major strategies. And it's possible to ameliorate degenerative aging processes. As we see, there are many proofs of principle. There are many proofs of feasibility in animal studies, but also some emerging human trials. There are several popular classifications of the major aging processes, such as the pillars of aging of the NIH Neuroscience Interest Group, or the hallmarks of aging, one of the most cited papers in biology. And for each such major process, we see some specific means of intervention that were shown to ameliorate aging in animal models and to improve the health span. So it is our goal, not just as longevity scientists, but also as longevity science advocates, to move these results as fast as possible to the clinic. Of course, there is nothing ontological about those classification systems. We can think of other classification systems. For example, we can classify anti-aging interventions as supplementation versus detoxification. We can also think of other groupings of aging processes with age-related diseases. But at least we see that there is a feasibility, the proofs of feasibility of such intervention, preventing age-related diseases and extending healthy lifespan. Of course, there are many obstacles on this path toward translating such therapies. One of the crucial ones is the integration. It is very nice that we have all those classification systems of aging process, but we are not exactly sure how those processes integrate with each other in the organism as a whole, and also in the environment. If we release some lifespan extended animal model into the environment, I'm not sure it will survive very long. So we need to think about integration, that we do not rejuvenate some system at the expense of some other system, at the expense of degenerating some other system. We also need to think about the results for the long term, that some short-term improvements are not followed by deterioration, as happened time and again in the history of rejuvenation. Actually, I wrote a book about the history of rejuvenation research. And we see it time and again. But generally, there is nothing mystical about intervention to aging. There are just many obstacles and many integration factors that need to be understood. And another crucial obstacles is the basic metrics. What exactly do we measure in addressing aging? How do we evaluate the effectiveness of therapy? How do we evaluate the safety of therapy? There's no consensus. There is no agreed definition. There are many particular systems. Pretty much every researcher has a system of metrics of his own or her own. So we need to have a greater discussion. What is it exactly we want to measure? How exactly we want to evaluate the efficacy of anti-aging treatments. Still, the main idea remains that by intervention into aging, we will be able to prevent multiple age-related diseases. not just a single disease or symptom, but multiple age-related diseases that are due to aging. And I'm happy to say that this idea is already entering the mainstream. Right now, aging, as of this year, is already included into the International Classification of Diseases, the ICD-11 system, not as a disease per se, but as two types of category. As an etiology category or causality category, the so-called aging-related code, and as a general symptoms category, in other words, a syndrome, the so-called aging-associated decline in intrinsic capacity. And I'm very happy and proud to say that this inclusion of aging into the ICD was done in large measures thanks to advocacy of longevity advocacy organizations, including especially International Longevity Alliance. You can see the Lancet articles that mention the International Longevity Alliance. The ILA is one of the contributors to this inclusion, and I'm very happy to also have taken part in this. But once again, this is just the first step. Right now, these categories are pretty much meaningless. We have this category, but what exactly do we measure? How exactly do we diagnose it? So that will be the next step in our work to define the evaluation criteria for aging, the criteria for efficacy, safety. On the one hand, to eliminate snake oil treatments. On the other hand, to encourage treatments that actually work. We've published a lot of position papers, a lot of articles calling for such a consultation to establish the good practices or consensus for the evaluation of aging. This is just the emergence of this work. Hopefully, we'll continue to develop it. Because right now, we don't even have the most basic agreement on definitions. How do I understand aging in clinical terms? Is it a disease? Is it a syndrome, polysyndrome, risk factor, underlying cause? How do we measure it as a frailty predictor, as biological age, multimorbidity? How exactly do we tackle aging in the clinic or hope to tackle aging in the clinic? All this will need to become subject of much further consultation. And there are many issues to be clarified. First of all, once again, the basic definition, do we even consider aging as a process or as a state? When we approach to diagnose it, how do we minimize confounding factors? Obviously, everything changes with age. Everything can be a biomarker of aging. So how exactly do we eliminate things that don't matter from what does? We need to think about the informative value, the most predictive value. But even with that, if we have the most informative and predictive biomarkers, we need to think about their practical utility. If they will only be available to a few people in California or Switzerland, they are no good to improve public health. So we need to think about issues like standardization, avoiding selection bias, cost effectiveness, affordability. All this will still need to be a subject of much academic and public and political consultation. But at least we can encourage this discussion right now. Of course, there are other evaluation criteria that were suggested, for example, by Moskalev and Kennedy's group, including primary selection criteria for geroprotectors, such as increased lifespan, secondary criteria such as evolution conservation of mechanism. There are the criteria of the American Federation for Aging Research. The biomarkers should predict remaining life expectancy and so forth. Early in the morning, we heard another evaluation criteria system by Eric Verdin. But of course, all this evaluation criteria far from the clinic will still need massive, first of all, academic and then regulatory discussion and negotiation to actually implement any of this in practice. Right now, it seems the most practical solution to address aging is the one suggested by Professor Nir Barzilai, who said simply, if we don't know how to diagnose aging as such, we know how to diagnose particular diseases, and then we combine our diagnosis and evaluate multimorbidity and the delay in the onset of multimorbidity of multiple diseases. And this approach passed through the FDA. The study was improved in 2015, TAME, targeting aging with metformin. 7 years passed, it didn't start, unfortunately, yet. But at least as a conceptual framework, I believe it is the most practical one at this point until we have a clear criteria for aging itself. And it was implemented in other frameworks. For example, here in Israel, they were started a program called Britain-Israel Research and Academic Exchange Partnership on Aging, BIREX Aging, where I had the honor to write the call for research proposals. And there we put specifically those geroscience-oriented goals, such as seeking new approaches toward predicting and treating multimorbidity as a proxy of aging. We believe this is a practical approach at this point, but hopefully also specific evaluations for aging will be established. Like Alexei said, maybe biomarkers, but also, of course, we know that the biomarkers don't always correlate with actual health status. So there are a lot of underwater stones to wade through. Still in our research, we try to do our part with my colleagues, Dr. David Bloch. We try to develop some metrics of aging and multimorbidity, especially utilizing information theoretical measures such as normalized mutual information and entropy. These measures have some advantages of the common measures such as correlation coefficient or linear regression because they allow to evaluate nonlinear regression, nonlinear correlations, and also synergistic effects. They allow to evaluate variability as a kind of proxy of adaptability in aging. I'm not a mathematician. I'm mainly responsible for the biological interpretation, for the general framework. David is responsible for the last part. At least this is one of the directions. Still, this is a drop in the ocean. We hope there are many more such projects that will somehow combine together and synergize to develop general acceptable metrics of aging, multimorbidity, and the efficacy of intervention. And I believe the most practical way to develop evaluation criteria for aging is by actually doing anti-aging testing. I'm very proud to have been involved in the study led by the chairman of this conference, by Professor Robert Chin-Hua Zhao, that evaluated the effect of mesenchymal stem cells in COVID. It was the first published scientific study that addressed this issue, that attempted to use MSC against COVID. By now, it has been published over 1,000 times. And it was also the first study that suggested the using of an anti-aging therapy, because we know that mesenchymal stem cells is a promising anti-aging candidate also against immunosenescence. So the connection with aging is directly, so perhaps by using an anti-aging substance, we could also ameliorate some of the severe outcomes like cytokine storms. And of course, this approach can be used with other substances such as melatonin or metformin or rapamycin. Anything that can affect immunosenescence may have had a positive effect in COVID as well. Unfortunately, this approach wasn't widely accepted, but still there's a lot of rationale in this, and hopefully we'll continue with this approach for other conditions and other health crises that are coming. And if we're speaking about recognizing aging in terms of not just methodology, but also of policy, we need to speak a little about advocacy. We understand that we may have the most scientifically grounded evidence-based criteria for aging, but unless decision makers don't accept them, unless they don't pass a regulation, we simply cannot use them to develop and utilize therapies. So it is important to also be involved in advocacy for aging research. That what we do in some of our associations. First of all, we even need to explain to people why addressing aging is important. Many people simply don't grasp it. So we need to explain that actually, if we are able to improve the healthy life expectancy even by 1 year, we can save billions and maybe trillions for the healthcare system, especially for a large country like China or the United States. And we basically need to explain to everybody, to the general public, to the pharmaceutical and medical and technology industry, to health insurance, life insurance, regulators, policymakers, the scientists, students. We need to explain how important the issue of aging is, how important it is to intervene into aging, to improve healthy lifespan. So there's a lot of educational work and advocacy work that we still need to do. And we can do it at every level, from the individual level to the national level. I'll just go very quickly of some of our initiatives that we did in our associations. First of all, the International Society on Aging and Disease is a primary organization, probably the strongest, if not one of the strongest in the world for longevity and advocacy. We published several position papers. One of them, the critical need to promote research of aging, was quoted over 250 times in scientific literature. It translated to 12 languages, submitted to several governments. recently the SOAD was accepted as a consultant into the United Nations Economic and Social Council. We organize massive conferences like the one in December 2019, where we established the UNESCO Anti-Aging and Disease Prevention Committee that Georgina mentioned. So a lot can be done through international cooperation, through international society, and hope we build on that and then develop further. And there are actually some results of this activity. I'm happy to say that already 5 years ago, in 2017, largely thanks to the advocacy led by ISOAD and many other organizations, we were able to include aging into the WHO work program. Can you imagine? It wasn't there. WHO, the World Health Organization, didn't think that aging is important enough for global health to include into its work program. So hundreds of scientists, hundreds of organizations wrote to them, and actually they included it. Here you have the head of the WHO aging department say the WHO listened. We included this topic with some metrics for healthy aging, quotes the ISOAD position paper. So it was one success, and this is just an example of what can be done through education, through advocacy to improve the awareness about the aging issues and the improvement about the awareness about aging health. And as I mentioned, ILA, the International Longevity Alliance, and other organizations, BGRF, are more active in including aging into the international classification of diseases. We published some papers in Lancet already, Lancet Health and Longevity on this. But once again, that's just the first step, some contribution. It's very far from bringing any actual results for public health, but at least it's a good start. And here in Israel, we also do our advocacy with our VETIC association, which is translated Seniority, the Movement for Longevity and Quality of Life. Also in 2019, we were able to include health and longevity research, development, and education into the Israel National Master Plan Aging that was published as a report by Knesset. As a result, there were issued some calls for research proposals where we were involved. You know, altogether, I believe we brought about $20 million for the field in Israel. Not a lot by some other country standards, but at least for us, it's good. And one of the successes was this BIREX aging program, the Britain-Israel Research and Academic Exchange on Aging. And I emphasize it because in the same ways that we established this program with the UK, between Israel and UK, we could establish it between Israel and China. It has been a very long dream of mine to establish such a cooperation between Israel and China. It can be fruitful, but it can also be between the UK and China, or between China and any country in the world, or between several countries at once. Because just through collaboration, we can really leverage and boost the field, even in terms of simple impact factor. You know, if different ideas combined simply by synergy, by cross-fertilization of ideas, we can produce much better results. And there's simply no end to such collaboration. It can be scaled up to any dimensions. Here we have some of the initiatives of which I was aware, or at least in some way involved. Starting from United Nations, through UNESCO, through British Council, through NIH. This collaboration can have no end, and hopefully also thanks to this conference, this cooperation will be increased, and we can all contribute to developing effective and safe health and longevity therapies for ourselves and our loved ones. Thank you. Thank you,
Ilia. That was great. Thank you. So we do have a question. Thomas, do you want to, Thomas Arnold, do you want to ask the question?
Yes, sure. Yeah, it was very inspiring. So a lot of new information, I think, for a lot of people. So Ilia, do you think we can slower aging and the speed of cell decline?
Yes, Thomas, that's the whole point. We have a lot of proofs of feasibility that it's possible to slow down aging or even reverse aging in animal models. There are some emerging promising human trials, but you know it's a long way from the lab to the actual human being, as they say, from bench to bedside. So that's where we're coming. A lot of lab work. So we need to help pass this valley of death from many promising ideas in the lab to actual human beings. But at least in principle, there's no scientific contraindication. It is not possible. So if it is not impossible, it means it's possible. And there are many proofs of principle. Also, as Georgina showed a few minutes earlier, there are many proofs of principle that it's possible to intervene in aging and improve health. But I hope to live to see it available for me and others. So that's where we come as advocates, as educators, science supporters.
All right. Thank you, and thank you, Georgina, as well.
Okay.
I think it's been done like via medicines or gene modification, like biotech, Ilia, if I may ask.
All kinds. With this example of Byrex aging, we set some very general goals to intervene into aging to prevent multiple age-related diseases. And we had about 200 labs submitting, 100 labs from the UK, 100 labs from Israel, each with a very different approach. Some are pharmaceutical, some are genetics, some are epigenetics. There's no end. We just need to pose this general goal of health and longevity, and you will see people come up with all kinds of ideas. But at least we pose this general orientation, this general direction. As advocates, as educators, we cannot be responsible for every single app. Everybody can come up with their own solutions.
All right, thank you very much.
Ilia, I have a question for you. It probably is difficult to answer, but can you tell us what you think is the biggest challenge facing us in terms of evaluation criteria for for evaluating aging health, healthy aging? What's the biggest challenge?
Yeah, I think you could even see it from one of my slides. The integration is the biggest challenge. You know where to start, you never know where to finish. Do evaluate the cellular level, the organ level, the tissue, organism, the universe. Where does this evaluation start? That's a problem of being a holist. A lot of people valorize a holistic view over a reductionist view. With reductionist view, you know where you start and you finish. In holism, you need everything. So basically, I believe the biggest challenge is integration, as much integration as we can have, to have actually working therapies that will not suddenly produce some unwanted side effects that we don't even expect, because we didn't integrate some of the systems that we needed to.
Okay, lovely. Thank you so much.